Perfect. Yep.
Great. Okay. So just to get started, just as some acknowledgements and disclosures, just wanting to thank everyone who contributed to this great work, including the expert panel members, and that no commercial support was received for the work or the presentation. So just to give you a sense of what we'll be talking about today, the first portion I will do, and then the second portion Ethel will do. And we're going to start with a background. We're going to talk a little bit about standards for mothers and babies in the postnatal period, methods and models for how standards can be delivered. We're going to touch briefly on an evaluation framework, as well as patient education tools, and then there'll be a time at the end for discussion. Okay. Next slide. Okay, so the purpose of the expert panel was there was 4 separate items that we looked at. We wanted to articulate standards of postnatal care for mothers and babies in the immediate postnatal period. And we also wanted to identify models for how standards should be delivered across Ontario. We wanted to touch on an evaluation framework or make recommendations about how standards could be evaluated, as well identify or develop any relevant education tools, so patient or client education tools to support the work. So the outcomes of this work are expected to benefit multiple groups, including mothers, babies, and families, healthcare providers, as well as the health system from community to hospital. Just a bit of background briefly. There's approximately 140,000 babies born each year in Ontario, and it goes without saying that there's a need to ensure transition from hospital to home is supported by the healthcare system. And these standards were developed to ensure consistency in practice that promotes safe and healthy transitions for parents, families, and baby. So I'm just going to talk a little bit now about a survey that was created at the beginning of our work, just to get a survey of healthcare providers. So our expert panel decided to create a survey and administer a survey to learn more about healthcare providers across Ontario and how they're ensuring effective coordination of care for moms and babies. So we surveyed over 110 healthcare providers representing each of the 14 LHINs in Ontario. So we had lots of survey responses. Most of the results were qualitative, but we did develop a report of these results since we did have a good response rate and there was interest from the LHINs to review the results as well. We also invited members of the public to share their experiences with us on how their care was coordinated when they were in the postpartum period across moms and families across Ontario. So in the survey, we included questions specifically related to each standard, but also general questions about any facilitators or barriers or any unintended consequences experienced. The survey was distributed through our contacts and networks across the province and as well via social media. It was open for a 3-week period in the fall of 2016. And as I mentioned earlier, most of the data was qualitative, and the data was reviewed by 2 individuals who verified topics and themes for each standard. And an analysis was also conducted of the overarching themes across the standards to determine items that were commonly identified, as well as opportunities for success, and then any gaps or areas for improvement across the standards. So now I'll just get into a little bit more information about the individuals who responded to the survey. So as you can see, LHINs from there was responses from every LHIN in the province. And as I mentioned, it was distributed through existing maternal child listservs, such as the Champlain and the Best Start listserv. And each LHIN also coordinated dissemination of the survey. And we also send it out broadly across our contacts, across the expert panel. Okay, and the next portion, we have a polling question for the group. And so we're just trying to get a sense of where our listeners today are from, which area. And so you have 4 options to choose from.
Thank you, Shannon. So we want our viewers to click on either if you're from the Greater Toronto Area, Eastern Ontario, Western Ontario, or Northern Ontario. We've had 39 responses. Okay, so we have 49 responses. So it looks like 16% of our audience is from the Greater Toronto Area, 29% is from Eastern Ontario, 37% is from Western Ontario, and 18% from the North. Okay, so that takes us to our next polling question. What type of community are you from? So we're really just trying to get to know who we have with us today. And your options are urban, rural, and remote. I've included some definitions in there for you. We have 44 responses. Okay, so with 48 responses, 69% are from an urban community, 31% are rural, and 0% from remote.
Okay, so the next slide here just talks a little bit about what type of institution respondents worked at or were affiliated with. So most survey respondents worked at or were affiliated with a level 2 hospital, followed by a community level hospital. And that brings us to our next polling question. And Laura, I'll let you take that over.
Okay, so what institution are you affiliated with? So your options are birthing center, community, level 1 hospital, level 2 hospital, level 3, or other. Okay, with 53 respondents, 0% from birthing center, 28% from community, 11% from level 1 hospitals, 23% from level 2, 13% from level 3, and 24% from other.
Great, thank you, Laura. That gives us a good sense of who's listening into the webinar, and hopefully this webinar and the standards that we discuss will be helpful to people working in every area of the health system. So as I mentioned earlier, an analysis of the overarching themes was conducted to get a sense of the main opportunities and the main areas for improvement or gaps across the standards. So in looking at all of the qualitative data that came in, 4 overall themes were identified. So strong partnerships to support a continuum of care was one of the themes, and really what respondents were talking about was good communication and interprofessional relationships to ensure that the right information is shared at the right time. Resource sharing and optimization of that. So optimizing system efficiencies by pooling resources with partners or relying on the expertise of other providers to carry out services. And the examples in this theme really were examples of integration of services where maybe hospital and community, for instance, had integrated some of their services to better support families. The third theme was health equity. So the type of care a patient receives being dependent on where they were located or who their care provider is. And the last theme, the role of midwives. So there was some qualitative data indicating that midwives, are providing patients with unique opportunities, but really highlighting the requirement for good partnerships with other healthcare providers so they can make referrals and for services that they for themselves may not be able to provide, and they can ensure that their clients are supported throughout the transition. So the presentation of results, so everything that I just spoke to, you can find that all of that information on the PCMCH website, the Provincial Council for Maternal and Child Health website. The report is available online, and it's really presented in a succinct way where it talks about the facilitators' areas for improvement, and then there's some of the data, the quantitative data that was shared with you in the slides. So make sure to take a look at that. And now I'll hand it over to Ethel to talk about the standards for mothers and babies in the postnatal period.
Okay, well, thanks, Shannon. So I'm just going to go over a bit about the process that we took in terms of identifying these standards. And what we did was what we wanted to do was to articulate the standards of postnatal care for mothers and babies in the immediate postnatal period, but to come to a consensus as to which standards to include, and then also to define the appropriate time frame. What we did was for each standard, we identified who set the standards in Ontario for each of the topics. For example, Newborn Screening Ontario for the newborn blood spot screening, and NCYS for Healthy Babies, Healthy Children program. For some of the topics, for example, maternal mental health and safe sleep, relevant guidelines and literature were reviewed, and specific expert panel recommendations were made. We also conducted a stakeholder consultation with each group that was responsible for some of these guidelines in Ontario. So, for example, Newborn Screening Ontario was involved in the newborn blood spot screening and the CCHD pulse oximetry standards. And then we consulted the BFI office, Ontario office for the breastfeeding standard, and the Ministry of Child and Youth Services for infant hearing program. And finally, we also consulted the members of the hyperbilirubinemia QBP work group for the standard regarding jaundice. So this is an example of the report format. That includes the specific topic, and then a statement of the standard, including the actionable and the measurable. And you'll notice that it's really doesn't have a lot of information presented, so it's easy to read. And they also includes a responsibility chart corresponding to each standard, and links to patient education resources. So the newborn standards that were identified were the following: jaundice and hyperbilirubinemia screening, newborn blood spot screening, pulse oximetry screening for CCHD, infant hearing screening, newborn exam. And for those that involve both mom and the newborn, those were breastfeeding initiation and support, safe sleep, healthy babies, healthy children screen. And the standards related to moms specifically are the maternal physical assessment as well as maternal mental health. So we're going to move on to some of the recommended models or methods to facilitate the coordination of quality postnatal care for mothers and babies in Ontario. And for this, the expert panel reviewed and identified methods that were reviewed in the literature, and we went through all of this and put together 5 different methods that can be considered in ensuring that there is good coordination in the postnatal period. So we're going to go over these in the next couple of slides. So the first method would be an effective communication method. And as we know, this is important in terms of ensuring that relevant, pertinent health information is passed on from healthcare provider to the community. It will facilitate effective communication of pertinent healthcare information as the families begin this transition. Many places may have a document such as a discharge summary. Of course, this is not particularly standardized. However, this information is very important as it can relay important information about feeding, social or healthcare concerns identified prior to discharge, and any follow-up tests or appointments that are required. We also recommended a tool such as an Ontario-based maternal newborn passport, which has been implemented in some places such as in BC as well as in the UK, but it's typically a booklet that is held by the mother or parent and contains relevant information for the mother to think about and discuss with her healthcare provider. The benefits of this passport would be that there's minimal change to the processes for the healthcare provider and the organization, and there's reported adherence by the care provider to guidelines in improving consistency. However, this is a tool that needs to be better studied to confirm its efficacy. And then consideration can also be given to an electronic format for a communication tool. And then there's the continued use of technology. We know that with strategic use of technology, care can be delivered remotely in real time through telemedicine, and providers can actually receive consults from specialists virtually. So to implement this, we can use existing technology for remote monitoring and potentially use video conferencing. However, considerations for data security and confidentiality should be taken into account. And there's also limitations on relying solely on technology with communities with limited internet access, such as in Northern Ontario. The home visiting program is a program in whereby trained medical professionals such as public health nurses or midwives visit families in their homes to provide patient education and healthcare services shortly after birth. Studies have shown that home visiting can lead to higher exclusive breastfeeding rates and patient satisfaction scores. Models that currently exist include the Healthy Babies, Healthy Children's program, the LIN Home and Community Care program, and the midwifery model. There's also potential to utilize Ontario initiatives that are currently underway, including the Bundled Care program, which has been piloted in 6 regions in Ontario. And this program is meant to support short-term care at home once parents are discharged from hospital. However, core components of this program could be used, including remote monitoring, navigation assistance, and care coordination, as well as ambulatory clinic. There's also the self-directed care program that's being implemented for home care clients in certain areas in Ontario. And although this program is currently being targeted towards children with the highest need for intensive care, the concept of a proposed self-directed care program may be adapted to the maternal newborn population. And then there's the care coordinator model. This may be helpful in families, particularly those who are at risk for complications, to really help them navigate the healthcare system, ensuring timely and coordinated access to care in the immediate postnatal period. So this method has been popular amongst the older adult population in Ontario through the HealthLinks model of care. And this particular model encourages greater collaboration between local healthcare providers to better meet the needs of patients with complex care needs. So implementation of this should be done in consultation with the local LIN as well as public health units. And finally, there is the ambulatory integrated postnatal care model. This particular model has been described in the literature as a one-stop shop model where care providers delivering different services are located in a practice or an interdisciplinary clinic. So these clinics are staffed by healthcare providers such as midwives, physicians, and nurse practitioners and or nurses. And examples of these currently exist in both Ottawa, in the Monarch Maternal Newborn Health Center, as well as Vancouver's South Community Birth Program. So these centers have been providing postnatal care to families for up to 6 weeks postpartum. To implement this, there should be collaboration occurring within the LIN and LIN subregions to determine which postnatal services are required and to define the specific population that would benefit most from these services.
Okay, so that takes us to another polling question. So, which of these strategies is your organization currently using? Okay, so as Ethel has described, there's the communication strategy, continued use of technology, the home visiting program, care coordinator program, the ambulatory integrated postnatal care model, or you can select none of the above. So I'll give you guys a couple more minutes. We've had 29 responses. Okay, so with 41 responses, or 43 responses now, 28% state they use the communication strategy, 0% for the continued use of technology, 56% for the home visiting program, 2% for the care coordinator program, 0 for the ambulatory integrated postnatal care model, and 14% or 6 people stated none of the above. Okay. So considering that, which strategy would be the most feasible for your organization to implement? So, same options. This time we took away the none of the above. Okay, and so we have 33 responses. Okay, so 29% state they want to use the communication strategy, 9% said continued use of technology, 29% stated the home visiting program, 1% or 3% said the care coordinator program, and 29% said the ambulatory integrated postnatal care model. Okay, so that takes us to our next portion of the webinar, the evaluation framework, which we will have Shannon present.
All right, thanks, Laura. So the next couple slides are going to go through the evaluation framework we utilized, as well as a resource that was developed as a result of this work. So going back to one of the 4 original purposes of these standards, one of them was to develop a framework to evaluate this. And so I'm not going to be speaking to really detailed specific information. Just in general, I'm going to provide an overview as to what we're recommending communities and institutions do in terms of evaluation. So what we did was we identified existing relevant metrics or developed relevant metrics that corresponded to each of the topics that we included within the standards report. We ultimately decided to include metrics only for topics where there was no single organization or institution that was responsible for setting the standard. So for example, with Newborn Screening Ontario, we didn't need to reiterate or re-articulate newborn blood spot screening, because that Newborn Screening Ontario articulates that quite clearly. We also referred readers to the appropriate organization to learn more about the metrics they should collect or monitor. And we also identified relevant outcome measures that we would recommend others to collect. And the next slide just deals with some of those measures. So in terms of outcome measures, we are recommending that institutions or agencies or communities could collect provider and patient knowledge of the standards. So collect information about this and how they can effectively coordinate postnatal care for mothers and babies within that first week postpartum, as well as patient satisfaction measures or client satisfaction measures could be collected. In terms of process measures, unintended positive or negative consequences could be collected as measures, and an example of that might be, for instance, doing a health equity impact assessment of a program or a service that's being provided. In terms of indicators, there's two that I'll note here. So the newborn exam, the indicator that was developed or recommended within our standards document is the percentage of completed newborn exams within the recommended time frame. And for newborn blood spot screening, we've referred readers to Newborn Screening Ontario for that measure. And for patient education tools, the last portion of our work was to look at any gaps in terms of patient education tools that were required to support the work. So we were very fortunate that there's a plethora of patient education tools already available for most topics, as well as in multiple languages. So we did seek feedback from external stakeholders and the Standards of Postnatal Care expert panel to complete this work, and this gave rise to the Jaundice Parent Education Tool, and that was developed as a result of this work. So just a bit of background on the Jaundice Parent Education brochure. So the hyperbilirubinemia QBP group identified the need to develop a parent education brochure that could be used provincially in a standardized way, and PCMCH worked with the Best Start Resource Centre and Public Health to develop the brochure, and it is based on Canadian Pediatric Society guidelines, and utilizing contacts at the Ontario Medical Association and AOM and other organizations, as well as social media for parent caregiver input. We received 101 healthcare provider responses and 7 caregiver parent responses in total, and to get some feedback on the resource. The questions we asked were centered around content, format, and other general comments for how we could improve the resource. And what you're seeing on the screen now is the end result. And just wanting to recognize Dr. Paul Rumialitis and his graphics team at Eastern Ontario Health Unit for really spearheading this. So this resource is available online at Eastern Ontario Health Unit's website, as well as PCMCH's website. And so I think that concludes the webinar, and we're going to enter the discussion phase, and I'll hand it over to Laura.
Yeah, so we'll now begin the Q&A session where you can send questions to the presenters. Only you and presenters will be able to see all your questions and not other attendees. If you do choose to ask a question, we kindly ask if you could enter your name and affiliated organization to the start of your question. And for this webinar, all the questions will be answered verbally by the presenters, but you'll be able to type in your question. So I'm going to enable a Q&A tab. It should pop up on your screens. So, all right, so it's now loaded. Please feel free to add a question into the box. Please kindly put your name and your affiliated organization prior to the question, and we'll read it out loud for everybody and have Dr. Ying or Shannon answer it. Oh, by the way, someone had asked about our brochure and where it was available. If you missed that, it's actually available on our website at pcmch.on.ca. All right, any questions? Okay, we'll give you guys a few minutes, and if there isn't any questions, we can conclude the presentation. Unable to load questions. Okay, Nicole, do you want to type out your question in the box? So we have a question from Susanna. Could you give us more information about the passport? And I think Dr. Ying, you referred to the discharge pamphlets.
Right. So I think this came about from the expert panel. I think there were some people who were familiar with passports that were utilized in the UK as well as in BC. So it's something that the family would carry with them, not only during the newborn period. It would have all the information from the antenatal period and beyond, and throughout childhood. So it actually has a lot of the health information, and they would bring that booklet from care provider to care provider so that that information is always available should any questions come about. And so we looked at this, and we actually looked at some of the literature around this, and there are benefits to it because it's very consistent information. However, there's also some information as to whether or not it is utilized as well as we think it should be. So I think they looked at it in BC, for example, with regards to immunizations, and it may not necessarily be utilized as well by all, although the concept seems to make a lot of sense in terms of consistency of communication.
Mm-hmm. Okay, thank you for that. We have another question from Tina Brennett from the Porcupine Health Unit. How was the jaundice picked as a topic out of all the possible topics? I know there was a QBP done around that. Shannon or Ethel, would you like to answer that?
So I think jaundice is always important in terms of follow-up, and the time period that we were looking at was the first week. So it was important. It was like one of the key priorities for ensuring that there's consistency across the board in terms of follow-up and timeliness of evaluation for jaundice. That was, and with that, we just went back to the QBP because it is an identified priority in the newborn period. And therefore, we reviewed everything that had been done and kind of put it all together in one place to make sure that that information was consistent across the board in terms of follow-up and evaluation for jaundice.
Yeah, I think it's Shannon here. I think I'll add to what Ethel said. It's really in terms of why jaundice was identified. I know at the expert panel level it was identified as a gap, and wanting to create sort of a single place or a single resource that parents and families could utilize. Whereas a lot of the other topics that we included in the standards really had kind of very well known or well utilized resources already associated with them.
Okay. We have a question from Michelle Basico. She says, is there any communication going out to the LINs to inform physicians that they need to see newborns within the time frame of 24 to 72 hours?
Yes, so this information as part of the standards was sent out, and this information has been disseminated by the PCMCH. It's available on the website as well as through emails.
Mm-hmm. We've disseminated them to all the major key stakeholders, such as the AOM, the colleges of physicians, and through CEOs of all the hospitals. Someone from Peel Public Health. They made a comment, the HBHC screen question 27 is about maternal or caregiver mental health concerns, past or present, perhaps not a good indicator of maternal mental health. So is there a question or comment around that for Shannon or Ethel?
Well, so I Shannon here, and from a public health perspective, there was a lot of talk at the expert panel about maternal mental health, and we did have the benefit of having Dr. Cindy Lee Dennis as a member of the expert panel. So in recognizing that maternal mental health is evolving right now in terms of the attention that is being paid to it, and so the recommendation related to maternal mental health and the HBHC screen was what we ultimately decided to put into the standards document, in recognition that there's lots of work going on right now in terms of research and development of systems and resources at the ministry level with Cindy Lee Dennis. So I think that I'll just leave it at that, but it was seen as a start in terms of standardizing how we do things, but maybe it's not necessarily where we want to end up.
Thanks for that, Shannon. We have a question from Deborah. How is Ottawa managing family health teams or FHOs, family health offices? Billing structure issues with integrated clinic concept, i.e. if we send patient to a clinic not affiliated with their family health team, there is a risk to the family health team funding, and yet patients are struggling to get appointments within 72 hours. Any comments on that?
I'm not sure specifically how the billing is working. However, this is for a very defined period of time, and it's usually for families where they do not have an identified care provider, or they will have difficulties getting in within the recommended time frame. So, you know, whether or not I would presume that families who are associated with a family health team would be or should be going to see those providers, and those providers should be, you know, trying to figure out how best to accommodate both moms and babies during that time period, with the identified concerns that we have in terms of follow-up during that first week of life period. But again, I think any organization or group that would want to consider a program such as the ambulatory integrated postnatal care model really need to look into your local LINs and sub-LINs, and as well as you can also consult some of the groups that are out there, like the Monarch Clinic in Ottawa, as to, because they've gone through this process, and they were very open to having other people, you know, explore an option such as theirs. They could be able to help out in terms of setting a clinic up like that, or a model somewhat like theirs.
Okay, thank you so much. For another question here, ideally, who should be providing the education around jaundice? I think everybody in the healthcare team really provides some of that information. I know as a nurse at the bedside in postpartum, we give a lot of that information. I don't know if Dr. Ethel, Ying, you have some other comments?
I think anybody who interacts with both mom and baby should understand the importance of jaundice, and to be able to provide counseling as to what to expect for the baby. So just both before the baby is born, after baby is born, when they go home, I think there should be consistency in the messaging around jaundice.
And we did have this included as part of the implementation considerations about whose responsibility is for the screening and interpretation of results. So I would refer you to go to check out the actual implementation final report to learn a little bit more about that. So MJ Trapnier, note that there have been issues identified with the use of the word passport. Some newcomers have been confusing this with real passports, and in our region we call it baby's first week. Oh, that's a really nice approach. I think probably call it different things. Is there a kind of a standardized way of calling it, or is passport just the model that these clinics have previously used?
I think it's really more just the idea, the concept of a document that's carried around with all the health information for a specific patient or child.
Okay. Peel of Public Health has another question. How can we reduce the risk of neonatal jaundice?
I think it's really understanding jaundice and the time frame with which it will be noticed and diagnosed as being a concern, so high levels of jaundice. And I think by some of the strategies that we've listed in the standards, early follow-up, and ensuring that the family is well supported in terms of that care piece, the follow-up care piece, will help in reducing the negative outcomes related to neonatal jaundice.
Okay, so Deanna Perks had a question about, are ambulatory integrated postnatal care centers usually created outside of the hospitals, such as a community center?
I think it varies. I think it could be at either site, like it either could be located within an acute care facility or institution, or it could be in the community. So I'm not clear, Ethel, maybe you can help me out here, but I know Monarch is located is it not located within
It's
acute care facility?
No, it's not. I think they're affiliated with 2 hospitals, and for families where they don't have necessary follow-up with a specific provider, they will be sent to this clinic, and they'll assess the family for, I believe it's the first week or 2 of life. It's not definitely not longer than 6 weeks. So I think there are communities who might have this externally, like the Monarch Clinic, but there are others who will actually develop them within the hospital itself as well. I think it really depends on the community and the resources available.
So we have a question from Jolene Burgard. My question won't come through. Sorry about that. We're having some technical issues with the Q&A, but hopefully this will suffice in the meantime. She was wondering if we had come across a catch-all passport, checklist, or resource that includes these standards and other postnatal needs. For example, possible referrals and when to make them.
I don't think we did. Like in all the research and environmental scanning work that was done, I don't think we came across anything that sort of had everything in one spot. Ethel, would you agree?
I agree. Yeah.
It would have made our work a lot more simple, I think. Yeah.
Yeah. Okay. If communication has occurred, is there any resource or recourse or alternative actions if physicians are not meeting the discharge requirement? Is that in regards to the jaundice?
Or follow-up in newborn exam?
Follow-up in general, maybe?
I think that would be for the organization and the institution to look into. I mean, there are very specific recommendations and guidelines, and when we put these together, we reviewed recommendations from CPS. I think from Ola, was it also the family practice guidelines as well?
And the American
Academy of Pediatrics. So we did review many guidelines, and before we put these recommendations together, it would really be up to the institution or the providers, like, to kind of make sure that this message is consistent with anybody who's providing care for moms and babies overall.
Unfortunately, with a lot of the work that PCMCH does, there isn't necessarily direct accountability that exists between the care provider and PCMCH. So, similar to other professional organizations, we will produce kind of the best practices and the guidelines, but then it's up to the care providers and their CEOs and hospitals to determine what they deem to be a priority, and then determine what kind of action would occur if those standards aren't being met, but that doesn't occur between PCMCH and that care provider. But like we've mentioned, we have communicated this to the LINs, and through webinars and other knowledge translation activities, we're hoping that there will be more support for this work, and so that kind of accountability piece can then be also built in between the LIN and the hospitals themselves.
Okay, so we have another question from Deanna Perks. We have many pediatricians who are okay with seeing the baby 7 days postpartum. This has become an issue as we are not meeting the standards. Okay.
I think this is something that you need to really take back to the group and the institution, because again, these standards have been recommended based upon other guidelines that are available by other national organizations. And we do know that a baby that is seen early on, that is important to follow up for in many reasons. It's not only for jaundice, it's for feeding, it's for support and checking in on the mom. So there's many reasons why a baby should be seen within the time frame that is recommended. If this is not the case in your area, then that's something that hopefully you can work together and figure out in terms of how to utilize the resources. So it may not necessarily be a pediatrician who sees them at 7 days. Is there another healthcare provider who can see the baby within that time frame that's recommended?
Mm-hmm. Great. Do we have any more questions? Okay, so Michelle Basco has a question. How do we get buy-in from the LINs to implement an ambulatory postnatal care model? Shannon, do you have any ideas?
Yeah, so I think that's first of all, the model, the ambulatory integrated postnatal care model can look differently. And what we found when we surveyed healthcare providers across Ontario was some people had, like for instance, Monarch, where it's sort of the one-stop shop and everything under one roof and all types of services for mom and newborn. And then others might have had some type of ambulatory care model where it was, for instance, focused on infant feeding, specifically focused around breastfeeding, or specifically focused around another postnatal service. So first of all, there was a continuum of ambulatory care models from, issue specific or topic specific right through to the entire postnatal area, like all things postnatal. So that's the first thing. And then I think the work that's being done right now by the LINs across Ontario, through the sub-region planning model that's been implemented in all communities across Ontario, I think that is an excellent spot. If either yourself or representatives from your healthcare agency sit on that collaborative group at the sub-planning region, that would be a great forum, for instance, to bring these standards and to talk about some of the items in this standard, in these standards, including the ambulatory, like the integrated model, and that just sharing some of the successes that have been had in other areas that have done this. So I would say, in terms of buy-in from the LIN, it may be less about buy-in from the LIN and more about presenting it to the LIN as a viable option that's based in evidence, and these standards could help you doing that. And I know across Ontario there's lots of sub-region planning taking place as part of the Patients First Act and whatnot. So I'm not sure if that addresses the question, but that would be my recommendation if you want to get something like this on the LIN's radar in terms of funding and whatnot.
And just to piggyback on that, Shannon, one of the things in the implementation report that followed that first report of the standards and the recommendations, we do also note that it's really critical to, look at all of these different strategies as, suggestions for things that could be done. And it's not to say that, a one-stop shop is better or best. It really should be driven by the needs of the community. And so in that second report, we really do highlight that, doing that kind of first initial needs assessment to understand what the needs of that unique community are would be worthwhile. And then if, based on that kind of assessment, you do still see that something like a one-stop shop model would be best at addressing those kind of needs, then I think that really helps build a business case for the LINs and other, provincial or local, regional decision makers in terms of, trying to kind of implement something like that.
Okay, that's great advice. So Deborah has a question. She discusses the birthing institution can ensure that PCMCH recommendations are clear on postpartum check timeline and encourages the patient to get the appointment. Unclear on process when the patient is not able to get an appointment in that timeline, institution has discharged the patient. I think this will pose challenges without a metric measured by the community GPs reported out. Is that a consideration?
So actually, this timeline should not only be discussed with the families following the birth of baby. It's something that, there is a pregnancy, and the whole pregnancy journey is many months. And so there's lots of time to be discussing with the families and trying to find follow-up in the immediate postpartum period, even before the baby is born, even before they've gone through labor. And so this is something that should be really under every provider's radar prior to delivery. I think every institution is, again, very different. When babies discharge home from the hospital, some hospitals actually have tried to, knowing that a lot of families are not able to get into the offices in a timely manner, have been coming up with other models whereby they bring families back following discharge to ensure that these babies and moms are seen in a timely manner. That may not work in every area, but it's something, it's just a model that can be considered. Likewise, depending on what your resources are available, it may not be in the physician's office. It could be in another clinic with somebody to support breastfeeding and check the weight and have a look at the jaundice. So, these models can be quite different depending on what resources you have available. And again, I think that conversation with the mom should begin before the birth of the baby in terms of anticipating what the next steps are once the baby is born, i.e. finding, deciding upon a place to follow up in the postpartum period.
Okay, so we have time for this last question. Tina Brunette from the Porcupine Health Unit. Who takes the lead on making these changes? I feel that if no one is assigned this task, none of this may get done. Any advice, Shannon?
So I think it's sort of like everybody who's here at this webinar is now aware of these standards, and if you can champion these in your agencies and institutions and your communities to bring awareness to them. I'm from public health, so my lens is community partnerships and that work to, increase community capacity to respond to best practices like this and to implement best practices like the standards for postnatal care. So what I know this isn't necessarily assigning it to one entity or one agency or even sector really, but it's more just looking at it as a collaborative. So championing it within your own organization, I think, bring it to the attention of your primary care providers in your community. Bring it to the attention of your local birthing institution and midwives and all of those partners that we work with every day to ensure moms and babies and families are healthy and transition well through this period. So as well, just to bring people back to the actual standards and within it talks, within the standards, we do have, it's fairly clearly outlined sort of who the expert panel felt was, most likely responsible for the standard and how that could happen and what that could look like, and then outcomes to measure it. So I know for sure in my community here, we're talking about this right now with our local birthing institutions as well as community agencies who work with pregnant and parenting families. Yeah, Ethel, I don't know if you have anything to add to that, but that's sort of my take on it.
No, I think that's great and makes sense. I mean, hopefully everyone's will be taking something away from this webinar in terms of advocating for these moms and babies in your community. It's really what we want to see happen. I know there will be many challenges ahead, but really we do want to get the message out just to make sure that there's optimized, consistent care for this population in Ontario.
Perfect. Thank you so much. So with that, we are concluding our webinar. So just to let you know, this webinar will be recorded and be posted on the PCMCH website in the coming weeks. The documents and tools that we've discussed today are available online for downloading. And your feedback is important to us. A post-event evaluation form will be sent to you via email. If you have any questions, feel free to email us at info@pcmch.on.ca. Thank you very much.